Welcome, everyone. Good afternoon. My name is, good morning. In fact, my name is Dr. David Roberts. I am Dean for External Education here at Harvard Medical School, and I'm very excited to welcome you to this event. Thank you so much for attending. I just want to let everyone know, as you just heard from the announcement, this event is being recorded, and the recording will be shared with all the registered attendees. I want to give you a little bit of background about this event. And in fact, it's part of something called the Lyme Wellness Initiative. We were very fortunate to receive a very generous gift from the Fairbairn Philanthropic Fund back in 2020. And the purpose of this fund was to create educational materials and events that raise awareness of Lyme disease amongst the general public and to help people all around the world with Lyme disease improve their quality of life. We have done a number of things as part of this generous gift, including launching a website that you can find at www.lyme.health.harvard.edu back in July of last year, 2022. And the website is really an amazing resource for people who want to learn the basics about Lyme disease, as well as those of you or others you know who are living with Lyme disease. And one of the things that we have made a very high priority in this work is to bring in the patient experience. So we've done a lot of work on this. We've conducted extensive patient experience surveys. We've received more than 400 responses to those surveys, and those have guided the questions and concerns and topics that we've addressed on the website, as well as the subject and the nature of today's discussion. So let me tell you a little bit specifically about the event today, which is called Optimizing Your Life with Lyme disease, transforming your personal story. Our patient experience survey data revealed some very important common themes about the impact of Lyme disease on quality of life, including notably an impact on the sense of identity and purpose. And we heard loud and clear how, and I use quotes here, but it's real, how invisible illnesses like Lyme disease with symptoms that are not always apparent to others can come with the added stressor of being dismissed or disbelieved by family, friends, and even health professionals. So today we're joined by two very thoughtful faculty members and colleagues, Dr. Annie Brewster and Dr. Nomi Levy-Carrick. And I think you're going to hear that both of them are going to talk about the impacts of complex illness and offer some very practical strategies for working with them and through them. And after their presentations, both Doctors Brewster and Levy-Carrick will have a conversation around the common themes of their talks. And then I'll be back and we'll answer some questions that we've received ahead of time from all of you. I want to note that due to the complexity of this, we will not be accepting questions during the program, but we hope that this really does stimulate a lot of learning and additional questions that you can follow with. I want to first bring onto the screen Dr. Annie Brewster. Dr. Brewster is an assistant professor of medicine here at Harvard Medical School. She's a practicing internist at Mass General Hospital. Dr. Brewster was diagnosed with multiple sclerosis in 2001. And in 2013, she founded the Health Story Collaborative, integrating her personal experiences with research supporting the health benefits of narratives. Narratives meaning story and sharing those stories. The Health Story Collaborative helps individuals navigating health challenges, find meaning, and ultimately through healing through storytelling. Dr. Brewster has written a book, The Healing Power of Storytelling, using personal narratives to navigate illness, trauma, and loss, which was published last year. And today, Dr. Brewster will present the science that supports the health benefits of storytelling and will share practical strategies for integrating your medical diagnosis into your own personal narrative for the sake of your own optimal health. I'd like to really welcome Dr. Brewster. Thank you so much for spending time with us today. We look forward to hearing your thoughts.
Thank you so much, Dr. Roberts, and thank you to the Lyme Wellness Initiative. I'm really happy and honored to be a part of this. So as was just said, my name's Annie Brewster. I am a practicing physician at Mass General, internal medicine, also a patient living with MS, and the founder and executive director of Health Story Collaborative, which is a Boston-based nonprofit. And as Dr. Roberts said, basically the short version is we use storytelling as a healing tool. So we are committed to creating forums in healthcare to help patients' loved ones, and healthcare providers to share stories, ultimately with the goal of helping people find meaning and move forward in the face of illness, trauma, and loss towards optimal health. So really, I want to say at the outset that we define illness and healing very broadly. So we consider illness as any imbalance in physical, psychological, or spiritual well-being, and healing as moving back towards balance and wholeness. So most of us are going to fit in that category in our life. And I myself really came to this work out of my lived experience, both being on the physician side and sort of seeing what's broken in the healthcare system, but also being on the patient side. And I'd say I was more motivated really by being on the patient side, as getting a diagnosis of a chronic illness and then figuring out how to move forward from that place. So I'll tell you a little bit about my story as a starting place, and then we will get to some of the science. But I feel like starting with my story is sort of walking the walk. I have to do that because that is really what helped me to heal. And a lot of what I learned in this work has been really central to my own healing journey. And I hope that you can apply some of it to your healing journey as well. So first of all, my story of a doctor. So I went into medicine a little bit late in my life. I was 27 when I started, not really late, but for medical students, I didn't go right out of college. I was actually quite ambivalent about going into medicine for a lot of reasons, but I kept getting pulled back into it. And it was really the stories that drew me. It was a pull that I felt, recognizing the privilege really of being with people intimately, hearing their stories, often in the midst of turning point moments in their lives. And I really do think this is a privilege. I went into it really with the vision that now looks quite naive, of sort of thinking I could be like a doctor of 100 years ago, where I could know all my patients and the context of their lives, know their families, really connect with them. And unfortunately, the system really makes that challenging in primary care, which is where I started. And I found it really heartbreaking. So I started early in my career, and this was early 2000s, feeling like this system is broken. I was paid on productivity, meaning the more patients I saw, the more I was paid. I actually was penalized if I didn't. So right there, that set up sort of an antagonism, where if a patient doesn't come to an appointment for whatever reason, there was a hole in my schedule, my paycheck would take a hit. Obviously, I wasn't in it for the money. I was in it for the relationships. But that saddened me, because right there I saw that it's setting up sort of an antagonism between patient and provider, and that the system is really driven by efficiency and money more than it is by relationships. And that antagonism, where it's sort of setting patients and providers against each other, where the provider is feeling under stress and on a time system that is being imposed upon us often, and the patients, understandably, and I've been on that side, feel like they're not getting what they need and aren't getting enough. So neither are happy. And really, it was then that I started to think, how can I make this better? Recognizing that it's really hard to do in the exam room because of the time constraints. There are things we can do, and we can talk about that later, to make it more fruitful and to try to foster that connection. But I started to think, are there ways that we can bring this outside of the exam room and actually give patients a chance to share their stories? Because I was saddened then that, often the thing that had drew me to healthcare, to hear the stories of people's lives, often was there wasn't time in the appointments that I had, or people would wait till the very last minute and they're walking out the door, because that's human nature. And it sometimes takes a while to get up the courage to bring up what's most important. And then the appointment would be over and there's someone else waiting. So I started thinking then, how can I make this better? Then sort of on a parallel track at the same time, I became a patient. And this really is what motivated me, because it really hit me hard. And I had a hard time learning how to come to terms with that diagnosis. I was 32. I had a 2-year-old. I was going through a divorce. More importantly, I was someone who naively thought like I could bully, or just by bullheadedness, persevere my way through any challenge in front of me. It had worked that way to this point. I was an athlete. My body had worked for me. I wasn't someone who felt like I could deal with a diagnosis of chronic illness. So the way it unfolded is that I was a medical intern. I had some tingling in my feet that then ascended. It kept climbing up my legs. I ignored it. The capacity for human denial is always incredible, I think. I ignored it, but then it reached sort of my mid-abdomen, and I finally told my primary care doctor, ended up seeing a neurologist. A renowned neurologist, one that had his name on almost every research paper. But my experience seeing him was really not positive. I waited for a long time. Then I felt like I had about 5 minutes in the room. Of course, you're vulnerable, on with that little paper gown on, I was alone. And I was told, pretty quickly and with no room for maybe, that I almost certainly had a MS and I should start taking disease-modifying therapy immediately. And I recognize that it's probably very different from a lot of what people with tick-borne illness have experienced, in that I was sort of told too fast what I had and given a diagnosis instead of dismissed. I wasn't dismissed, but what felt dismissive was that I felt like I wasn't seen or heard as a person. Never once did the doctor ask me anything about what was important to me, what mattered, that I was, wanted more children, that I was young, that I was having, that I couldn't really come to terms with this diagnosis. And there was nothing was asked that led me to be a human being in that moment. So I left that office. I didn't see another neurologist for 5 years. I went into a long period of denial. And what I realized in this experience that I had never thought about as a doctor was that giving a diagnosis actually causes a huge identity shift. Sometimes as physicians, we are trained to come up with the diagnosis like detectives to solve the problem. We get the answer, we give the treatment plan, and we think our job is done, the story's over. And what I learned from the patient side is that's really when the story is just beginning, and that this process of trying to come to terms with a new diagnosis that's life-changing and chronic is very difficult, and it requires us to sort of rejigger our stories and tell them differently. And so I also struggled with a lot of shame. I didn't tell people for a long time, and I think that really came out of me not wanting to be forced into a certain category by people's misperceptions. I didn't want them to treat me as less, to think about what they understood to be MS and to put me in that category. I was nervous that my entire identity, if I said it out loud, would become patient with MS instead of the other things that I had that I cared about. So I really just denied it for a long time. But then over time, what I learned is that that was no way to move forward. It was painful. I was negating a part of myself. I was not going to be able to live my optimal life unless I learned how to integrate this and accept this into my life and move forward towards optimal health. And what I realized is this didn't mean glossing over the hard parts. It actually meant engaging with them and facing them head on. And so storytelling really helped me to do that. I started very gradually to share my own story, and I realized that in putting it out there and sharing it, I felt more whole. I felt less ashamed. And perhaps even more importantly, I recognized that my story mattered, that it actually had the power to help other people. Because it touched people. When I shared my vulnerable story, people feel more freed up to share their vulnerable story. It opens conversation, and that felt empowering. So I started thinking, how can I use my personal experience to actually help other people, help my patients? I knew that when I had first been diagnosed, I didn't feel ready to go into a support group because I didn't feel like I had stepped into this identity yet. But I was really yearning for stories of people's lives, stories of how people had moved forward, stories of hope and possibility, not necessarily of cure, but how can I move forward with these challenges, with this diagnosis, and live my optimal life? How can I face those hardships? How can I get new perspectives? I couldn't find those stories. This was a long time ago now, 22 years. And so I thought, I'm going to start creating a library of stories for other people to listen to with other diagnoses, not just MS, so that people can listen to true stories with a narrative arc, the hard parts, the good parts, all of it, the messy parts, and hopefully listen on their own time before they're ready to go to a support group. I was lucky at the time that I had a connection with the Boston Public Radio station, WBUR, and we created a series called Listening to Patients. And so that's sort of how I began this work. I'm going to share my screen now just to share a few slides with you. So ultimately, doing this work ended up leading me to starting a nonprofit called Health Story Collaborative. So I really was struck most by how powerful it was to give people the time and space to tell their stories. I had started this work thinking that library I would create for listening would be the most powerful. But in fact, I think just working with people, giving them a chance to feel listened to, feel seen and heard, and help them to craft it in a way that felt good, and then to put it out in the world if they felt like sharing it, to be witnessed, and how powerful that was. And so that led me to starting Health Story Collaborative, and we formally became incorporated in 2013. Initially, this work came from a heart place for me. It was really intuitive. I thought, obviously this works. I'd experienced it. I have felt it. I have been with people who have shared their stories. And I was sort of annoyed initially because I'm a doctor, and every time I would try to integrate it into the hospital, people would say, where's the data? Where's the data? Where's the data? And at that point, I thought, why aren't you studying this, or make it a study? And I was thinking, I don't want to study this. I want to create a service for people. I want to create a healing opportunity that we aren't offering in the office. And so I was a little bit sort of, annoyed by that, and that the studying felt sort of exploitative. And I was like, I don't want to do research. But then I was very lucky in that I met my colleague, Jonathan Adler, who's a psychologist who happens to study the health benefits of narrative. He works in the field of narrative psychology. I met him in 2012. I read a study that he had done that was looking at psychotherapy patients. And what they did is they followed psychotherapy patients over time. They wrote a story, a narrative at the beginning, and took a mental health assessment. And then after each session, wrote another narrative and took another mental health assessment. And what they found is that over time, mental health improved, but so did the theme of agency in people's stories. And in fact, agency changed first, and then improvements in mental health followed. So for me, that was really inspiring. I was thinking as a patient, and also as someone who was trying to help other patients. But as a patient, I will say, to think, okay, I can actually change my story and find the agency in it, and that will help me to improve my health. So I got to know Jonathan, and he has now the chief academic officer of Health Story Collaborative. So he's taught a lot about this field of science. And I want to touch on it briefly here. We don't have a lot of time, but I'll touch on it so that hopefully there are some things that you can carry forward into your own life. So first of all, the most important piece for me is this concept of narrative identity. And that's the belief that who we are is shaped by the stories that we tell about ourselves. So that's how we make sense of what happens to us. So it's not static, it's continually changing, but we are shaped by the stories that we tell, and we can decide which stories we're going to tell. They have to be authentic and our stories, but we're not stuck. They're forever changing. The other thing that is important when we're thinking about narrative identity is sort of what gets storied, right? So it tends to be deviations from the norm, right? If you think of all the things that happen to you in a day or a week, you can't possibly tell stories, or you're not drawn to tell stories about all those things. It tends to be the things that are different. So it's going to be high points, it's going to be low points, it's going to be turning points. So these key moments. So we create these experiences on purpose, vacations, going to psychotherapy, for instance, and these experiences happen to us. So illness is one. This is a big turning point moment. Also, good things can just happen to us, serendipities, but it's these big high points, low points, turning points that form the scaffolding of this narrative identity that is us. So to talk about illness, a sociologist, Michael Burry, has referred to it as a biographical disruption. So it is really just that. It's one of these big turning point moments that really shifts our life. It forces us, it disrupts our story, and it forces us to tell a new one. So when it comes to mental health, it turns out that not all stories are created equal. It's not so much about the content of the stories or what happens to us, but it's really about the themes that show up in our stories. So I'm going to tell you about those themes. These are themes that we work with at Health Story Collaborative when we're helping people to tell their stories. We don't necessarily name them, but we ask questions to help people identify these themes in their own stories and to develop them further. So I'll tell you about what they are. So first of all, on the positive side, associated with improvements in mental health is agency. So I already mentioned that one study that looked at agency. So the more themes of agency we see in stories, the better the mental health. And this is like themes of like being in the driver's seat, not just being batted around by the whims of fate, having some control over what happens. No one story is full agency, but we see some agency, some not agency, but the more agency, the better. So helping people to identify that, or looking at your own stories and asking yourself, like, what can I control? Or what did I learn that I then took forward and taught somebody else or changed my life in a positive way? Another is communion. That's themes of connection, relationships in our life that are powerful. That is associated with improvements in mental health. Another is redemption. So that's when elements of a story start bad but turn good. And that's good for our mental health, where on the flip side is contamination, when things start good and turn bad. That's bad for our mental health. Again, not everything is fully redemptive, but even in death, I think there can be redemption, right? There can be talking, deepening relationships, saying things that haven't been said, coming to peace with things. So there are always threads of redemption. Another is coherence. So it turns out that just going through the process of crafting your narrative, of thinking of all the bigger stories of your life, and in this moment in time, trying to craft a story that makes coherent sense, that's good for us, right? Remembering that our stories are constantly changing. So if I tell my story today, that's my story of now. And it might be different next time I tell it, but going through that process is important. And a lot of that scaffolding of those big stories will probably still be there. And then accommodative processing. This is my favorite one. This is when things happen to us, we either can assimilate them to make sense of them into our existing stories, or if something really big happens to us, like a diagnosis of a chronic illness, a trauma, we can't just assimilate it. We have to accommodate it. We have to change our stories to fit it in. And this is really hard. This is about meaning making. And this is also psychologically really productive and good for us. But it means we have to acknowledge the hard parts. So you can't tell stories that are just glossing over. It's not about skipping over the hard parts. It's about really delving into them and finding the meaning. So I'll say, just in summary, the takeaway points that I want to make, that I, as a patient, felt empowered by in learning about this work and in doing it, is to remember that we can't always control what happens to us, but we can control the meaning we make out of what happens to us, reflected in the stories we tell. And John Adler has always said, and I love this, that we sometimes forget that we are both the main characters in our stories and the narrators, right? We remember that we're the main characters, but we're also the narrators. So we have some control over that process, and there are stories to tell. And then the other thing that I find empowering is just to remember that our stories are not static. We are not stuck, that we're always constructing and reconstructing the stories of our lives, and that we are in the driver's seat in that role. So I will stop there and unshare my screen and turn it over to Nomi, Dr. Levy-Carrick, who I look forward to hearing.
Thank you so much, Dr. Brewster. That was fantastic. We will come back to a number of those themes in the question period. I want to turn now and welcome to the screen Dr. Nomi Levy-Carrick. Dr. Levy-Carrick is an assistant professor of psychiatry at Harvard Medical School. She is a medical psychiatrist and has a number of different roles. She's the vice chair for clinical programs in the Department of Psychiatry at Brigham and Women's Hospital. She is co-chair of the Brigham and Women's Trauma-Informed Care Collaborative. She is a psychiatric consultant to the Critical Illness Recovery Program at Brigham and Women's. And she's had a longstanding and an abiding interest in integrating mental and physical health approaches in ways that are mutually reinforcing. So today, Dr. Levy-Carrick will discuss the principles of trauma-informed care and explain how a trauma-informed approach can empower patients, including each of you or people you know, and help to create a very powerful patient-provider dynamic. So thank you so much, Dr. Levy-Carrick.
Thanks so much, Dr. Roberts. And I don't know how you follow Annie Brewster. This is an inspiring story, but also one that I hope will inform some of the sort of structure and narrative of what I'm going to talk about. I actually went to med school when I was 30. And so I think this process of kind of non-linear travels in our lives and kind of recognizing that there are these different stages, maybe a common theme in our willingness to kind of engage these issues in different kinds of ways. I'm going to share my screen. And in the next 15 minutes, try and run through kind of what and where medical trauma is, the principles and practice of trauma-informed care, and then thinking about how does that give us some strategies for managing chronic illness. So trauma, we hear a lot about trauma. What is trauma, right? It's a kind of experience of people used to think of it as just the physical trauma, right? It's sort of a break or a tear. But what we understand it to be is it's something that overwhelms our resources and in the end creates some sort of disruption or dysregulation. And sometimes that is that the event itself is so overwhelming that it does that. And sometimes it's that there are so many events happening in quick succession that there's no opportunities for recovery. And often it's both. And we recognize that it's not just individual trauma, but there's also interpersonal trauma and collective trauma. And we recognize that even happens in the context of sort of structural trauma and structural racism, for example. In this country, we've been thinking a lot about that. But it's each of these, and for most people, it's some combination. And so when we think about it in the context of chronic illness, there's the kind of acute or chronic illness or the symptoms that we have that sort of drive us into the medical system and then potentially getting that diagnosis. The interpersonal part, how'd you get the diagnosis? What was the context of that? Who did you tell? Who was there for you? And then the whole process of engaging the medical system and also engaging our families and engaging, everyone around us, sometimes work colleagues. And so that's the kind of interpersonal piece. And then the collective trauma. That sort of can be a source of great strength, but also when you're feeling dysregulated or more isolated, it kind of starts to, again, feel like there's a greater disruption. As Dr. Roberts said, I'm always really focused on what Candace Pert used to call the body brain. The brain and the body are so closely interconnected and everything is bidirectional. For these purposes, we're going to sort of focus a little bit on the brain, but we know that sort of there's a whole cascade of things that happen when you have a traumatic event or you have a sort of sympathetic or adrenergic release. There are 4 domains that we know get implicated, and everything we kind of learn is around pathology, and then it tells us how things work. So when things go wrong and people end up with PTSD, for example, there are these different networks that are involved. And one of the core ones is emotion regulation and executive function. And executive function speaks to your ability to sort of plan and do things in ways that are kind of effective. And that could be like making a sandwich to sort of coordinating a much more complex schedule and sort of planning ahead. What we know is that the more dysregulated an individual is, the poorer their executive function, or the other way around. The better your regulation, the better executive functioning. And that becomes a really core theme when we sort of think about how we're optimizing our engagement with the medical system. The second is threat detection. And, what we find threatening is sort of based on all sorts of different experiences in our life up to that moment and thereafter. And so that set point, there's some genetic component, there's a lot of kind of experiential component, there's some really interesting work around intergenerational sort of ways that that's informed through epigenetics. But where that set point is really important and individual, and can change over time based on our different experiences. Fear learning, there's a special part of the brain in the amygdala that holds on to things that were extremely scary. And that keeps us alive, right? If you were, if you're trying to run away from a lion, you never want to forget where that lion was. But the other side of that is that we tend to remember the things that are more negative much more than the things that were positive. You can go through the day and like 15 things go right, one thing goes wrong, and at night when you like lie in bed, the one thing you're thinking about is the one thing that went right. Actually can take a lot of effort to sort of shift that. And again, sort of things that are adaptive in one context can become really maladaptive in another context. And that's that sort of theme that we want to think about. The last domain is contextual processing. And this is for me like kind of a center point and both fascinating and also really empowering. So contextual processing speaks to our ability to contextualize a particular event based on all the other components around it. It helps us, for example, in trauma, when something happens, it's as if time stops sometimes, right? When people are when they're thinking about the trauma, when they're experiencing it, it's as if it was happening again in that same time period. And when you're able to kind of process it, you start to gain perspective and you start to integrate that into the broader kind of narrative of your life. So the classic example is, if you go to the zoo and you see the bear behind the screen and you're saying, oh, wow, it's a big bear. Look at how it plays with its cubs. This is all really kind of engaging and enthralling and maybe even awe-inspiring. If you're walking in the woods and the bear's in front of you, you're going to have a completely different reaction. And you should, right? Like this is an appropriate reaction. But if every time you go to the zoo, you feel as though the bear is about to pounce, then you're experiencing the world in a way that's always immediately threatening, even though actually the context should help you feel a little bit more regulated. And as you're able to integrate those experiences, you're able to regulate better. And with better regulation comes better executive functioning. And you can sort of see how that all plays into one another. So why do we talk about that? In part because it helps us then understand how are we able to be resilient. And that's like its umbrella term, resilience, right? It's actually a bunch of associated traits. And there's some core ones, sleep, nutrition, hydration, relaxation, exercise. We hear about this all the time. You're sort of always, our goal is always to get enough of each of these things and we'll magically have some sort of balance and be able to bounce back when everything hits us. The fact is that that's one piece of it. And there's also around that all sorts of kind of more experiential components. And it's things like optimism, which really speaks very specifically to an ability to look to the future in a way that continues to show optimism, that shows options and the possibility for something better than exists in the moment. And that, an attitude to life is also sort of built on that. Focus is really interesting because sometimes with trauma, the focus narrows and like all you can think about is the nature of that trauma. And sort of at the same time, for many people, focus and attention are gone. It becomes actually very difficult to attend to the things you want to attend to because your focus is kind of shifted. And sort of thinking about that and the ways in which that's happening can be really important. And emotional awareness, one of the things that's compelling about narrative is that you're finding language to explain what happened. Sometimes at the time of trauma, there is no language. Sometimes we sort of think about other therapeutic arts that help people sort of try and get in touch with that because they have no language in that moment. But as language becomes really important because we're not just mad, sad, glad, right? Like if you're sad because you feel sort of, humiliated, that's very different than if you're sad because you feel lonely. And the things that you would do to address that would be different. And so those are the kinds of things that language can help us to then sort of tease out. What do we do next? Control in trauma, that locus of control, we call it, that your sense of control is somehow outside of yourself altogether. And that process of trying to bring it back is really kind of key and central, and finding adaptive ways to do that and effective ways to do that. Social support, we know at every level, our health and well-being is sort of as good as the nature of our relationships. And that is kind of, again, things that are in place before we receive a diagnosis, and the things that we need to then negotiate after receiving a kind of chronic illness diagnosis. And sort of thinking about ways to engage supports is a really important one. A sense of humor, you have to have a little perspective to have a sense of humor. So that's also a little bit, it's a sign of health if it's there. If you're someone who has it and you've lost it, so for some people that's a really good, like, oh, this is a bad day, so I can't even laugh at that, right? And when it comes back, there's sort of some sense of that. And then an ability to problem solve. We're back to executive functioning. Do I feel like I'm in control in some way of the way I'm responding to the world around me? So this is all great. We also know it's really hard. We can understand this at a kind of intellectual level, but then that visceral experience of it can be really different. And it's sort of understanding how we can get to that visceral part, the part that helps us integrate our sense of self, that's really important. I'm just realizing now that I have been using the wrong interface. Sorry about that. Hope that wasn't too distracting. So one approach to this is what we call trauma-informed care, a trauma-informed approach. There are 4 R's and there are 6 principles. The 4 R's are based on the fact, and a lot of this research came out of the fact, you pick any population and baseline trauma, the amount of exposure to some trauma in their lifetime is at least 70%. Any population, and it tends to be higher in other contexts. So if we recognize that everybody has some set of trauma at baseline, we want to understand how it impacts us and then think about how do we use that information for paths for recovery. We want to recognize that it impacts everybody in an organization, the patients, the providers, really like all the clinicians, the doctors, the nurses, all the other people, the staff. Everyone has something, and we want to respond by integrating that knowledge into things, that policies, procedures, practices that are going to just make care more effective. And we want to resist re-traumatizing people. We know once you're sort of had that, it's easy to get re-triggered. And when you're re-triggered, you get dysregulated and you're kind of back to feeling like the controls outside of yourself. So that takes an organizational culture. That means people need to really be thinking and talking about it. So what are the 6 principles? The first is safety, and not just physical, but also psychological. Sitting in a room in a little gown in the Johnny is almost automatically making people feel physically unsafe in some way. But there are other things. Psychologically, if you're going to have to tell your whole story all over again, you may not feel safe. If you feel like you're going to tell your story and you're expecting somebody to like not believe half of what you're saying, you may not feel safe. And so understanding how do we gain a sense of safety is a really important part of that. The second is trustworthiness and transparency. In a medical system, we're asking people to trust us, very quickly. Here's your 20-minute appointment. Trust me, right? How do we gain that? Transparency is a really helpful one. What can we do within a particular setting? How does it work? Depending on the number of different kind of procedures that you've had to go through, or even sort of appointments that you've had to go through, remembering that what's kind of self-evident for one person is very much not so for another, and figuring out for oneself what transparency can look like is really important, because that also then informs collaboration. And the kind of core of that is understanding and appreciating that the patient's experience brings a lot of information to the table, just as the clinician's experience will. And so how do we take both of these pieces and then work to sort of set some mutually agreed upon goals of treatment and care? So to do that, you need to sort of have choices that seem reasonable and feel like you can really use your voice to make those choices. The cultural, historical, and gender acknowledgement, we sometimes also think of that as cultural humility. This is not a whether, but a how, right? Being a female versus male going through the healthcare system is going to impact you. Understanding how that's doing so is really important. Your historical experiences, historical trauma, race can play a really important role to think about in those engagements as well. And culture, we understand, can be sometimes a source of support and sometimes actually a source of trauma, depending on how that's playing out in terms of at home. You know, people have a home culture and a ethnic culture, and there are lots of different cultures. Sometimes that's like something that surrounds you and bolsters you, and sometimes it actually makes you feel isolated, and being able to identify that is really important. And the last is peer support. And you know, one of the things this points to is that we all have many different identities. One of our identities might be based on our chronic illness, but it may be also based on other things we enjoy doing, whether it's professional identities or hobbies or other kind of things. And it's really important to recognize that at different times, we may actually want to be seeking the identity and support of different sets of peers. And, you know, recognizing the ways in which having peers who are experiencing a shared lived experience in illness is really important. But if that doesn't feel comfortable at this particular stage, thinking about other peers groups that might be helpful to connect with. So trauma-informed care is very different than trauma-focused treatment. Trauma-informed care, we're thinking about universal precautions. We're thinking about universal framing of a visit, for example, and we're really focused on optimizing engagement in healthcare across the healthcare system. How much you need to know, what you need to talk about, what you need to focus on will depend on your role and on the context of care. And that's very different than trauma-focused treatment, where you're really addressing the trauma experience directly. And that treatment is focused on the resolution of trauma-related symptoms. And in that context, sometimes you want to get into the details of a trauma history as part of the treatment. But there are a couple of things, you don't need to be a therapist to be therapeutic in your engagements. And I think that that's one of the things that, we can talk about the different ways in which clinicians in different settings can be really helpful. But also the idea of part of healing is about sort of helping people to regain that narrative and to kind of integrate experiences so that you can have this temporality where you feel like you can move forward. And again, there's lots of different kinds of treatments. But that is not what we're saying here. We're not putting everyone in mental health treatment. We're saying what we want is a system that can kind of acknowledge that we need to work with everybody around. So some strategies based on these principles. And we can talk more about that later, but I think just to kind of enumerate a few, for safety, one of the things is to really think about what makes you feel safe in, for example, an exam room. If you're going and you're not going to have a physical exam, maybe there's no need to be in there, Johnny, when you're having this conversation, right? That's absolutely worth asking to sort of say, do I have to change, and do I have to take all of it on? To feel empowered to sort of ask for those sorts of things. The other is, how much are you going to have to share and what are they going to ask? And sort of trying to work with all, sometimes when you have lots and lots of different specialists involved, really thinking about who's the point person and how can we get people to sort of know enough of your story that you don't need to go through it all over again every time you go for a visit. Transparency, again, like what's going to happen in what context. For some people, going in, you kind of feel like you're going in, you're supposed to see your doctor, but it turns out you have to go through this check-in, and then there's an MA, and then there's sometimes a nurse, and then there's sort of a lot of people along the way. By the time you get to the doctor, you already forgot all the things that you wanted to do and say when you got in there. And so one of the things, and it sort of builds on collaboration, is I am a big fan of coming in with a few things that you really want to make sure to talk about, because it's so easy to have that even if you're at the door, you're already better off. For me, it's like I leave the office and I'm like, oh wait, I meant to ask. So really sort of being able to decide, what am I trying to achieve in this particular encounter can be a really useful way of sort of thinking about collaboration. Voice and choice, really never feeling like you're going to be pushed into having to choose at that moment. and sort of saying, well, what are some reasonable choices here, and being able to kind of step back to do that. And then sort of thinking about and creating space for thinking about how culture, gender, or race might be impacting your engagement with the system or with that clinician in particular. And then peer support, I think this idea of figuring out what are my identities, sometimes what are my identities beyond my illness, or am I just sort of in there right now? And that's the main thing that I need. Really understanding that, I think, is a really important part of deciding what to do next. And the meaning making that Dr. Brewster was talking about, I think sometimes is really closely tied to this idea of, who am I, and with whom can I connect? Where's my social network? So I think I'm going to stop there, and hopefully we can address other questions as we go.
Thanks so much, Dr. Levy-Carrick. That was fantastic. I'm going to have both you and Dr. Brewster back together here. There are so many interesting ways in which narrative medicine and the power of storytelling connects to the ideas of trauma-informed care, and how do we bring those principles together. I have a son who has been through some challenging things, and we've often said, there are some stories that you tell and tell and tell, and the more you tell them, they're just really difficult, and you keep telling them, and it doesn't make anything better. And then there are others that are there's real power of talking through that. So I'm going to let you two talk together for about 10 or 15 minutes, and then we'll move on to the question and answer period. So thank you so much.
Thanks.
Hi. All right. I'm going to say,
okay.
I think you should call me Annie and I should call you Nomi while we talk.
Fair enough. I prefer that for sure.
Me too. Yeah. So where to jump in? There's so much.
I'm really interested, as somebody's sort of thinking about joining or telling their story. How do you help identify for people some sort of framework that meets them where they are, in terms of what language they have to bring, or where they are in terms of integrating that tale?
Yeah. So, I do think you made a good point in saying there are times when there aren't words yet, right? So there's a point of readiness that people have to be in, and that's really going to be self-driven. Often people come to us when they want to tell their stories, so they are making a choice there. Mm-hmm. I do think we've worked with people at many different stages, so people who've just been diagnosed versus people who've been diagnosed 20 years ago or whatever. So I think that self-empowerment there for people when they decide they're ready. Mm-hmm. Because in the beginning, sometimes there can be, you can use art or you can use dance, and there are other things before narrative. But at some point, I think going through the process of putting it into words and narrating it can be very much about integration. So is your question about sort of how do we decide when someone's ready, or what exactly?
Yeah, if somebody comes and says, I'd like to do this, but I don't know where to start.
Yeah, so we have a very specific framework. We have a narrative guide that people work with that's grounded in the science of sort of how people tell their stories. And it's very much what I said about sort of these turning point moments, right? Recognizing that not every illness narrative fits a turning point moment. Sometimes people are born with an illness, but there might be a turning point where you start to have a different awareness of it, or that shift. Or if it's a discrete moment of diagnosis where you were one way before and now you have this diagnosis and things have shifted, we deal with that. So the narrative guide is very much structured on sort of tell us about your before self, tell us about this turning point moment, tell us about your after self. But in those moments, one thing we know that's associated with coherence is that the more that you can be specific about details and really bring people into that scene with you and really connect to that scene in very sensory ways, that enhances coherence. So we're often pulling for like snapshot moments that tell us about a specific scene in your before self that represents who you were. And why is that important? Because that reflection piece is about the accommodative processing of why does this feel important? So we have this very structured guide, and then we're working with people through multiple rounds of edits. And we're often asking questions to sort of pull for those themes, help people develop them. So that's how it works. But I will say we've done it with people who aren't able to read or write, and we do it just orally. So we use the same narrative guide, but go through it in words. So it's pretty structured.
Yeah, it's really interesting.
Yeah. I was wondering, just listening to you speak about medical trauma, because I think that's such an important thing that many people who have navigated tick-borne illness have dealt with. So I wanted maybe to have you say more about medical trauma in particular and what that looks like. And also, I so appreciated a lot of the strategies you talked about for sort of trauma-informed care, but I was thinking of it with the patient lens on, and was sometimes I feel disempowered. There's a power dynamic that's inherent in that relationship.
Yeah.
So how do we as patients, like, we don't have as much control to help with the transparency or to help with the communication and collaboration, or at least it can feel that way, right? Because the system is set on a power dynamic. So how, as a patient, can we try and bring those tools in?
I feel like you asked two questions, and
I probably did.
I've lost the first one now.
Let's just to talk a little bit more about what specifically medical trauma looks like.
Medical trauma, right? So
Yeah.
I think that's helpful, and that probably does inform the second part. But so medical trauma can be anything from somebody who hates needles and had this experience of like being held down in a way while they were getting that done that was just made them feel completely trapped and loss of control, to people who have been in the intensive care unit and intubated and having kind of all these. People will sometimes have sort of memories that are kind of hallucinogenic, that feel more real than anything else that happened to them. And it becomes really hard to tell, like, what was real, what wasn't, why, and so forth. So it really spans the gamut from that. People who have pre-existing trauma, we want to sort of think about a physical exam is like not just a neutral thing. And I think sometimes in medicine, we're like head, shoulders, knees, and toes, and you kind of work your way through it. But really sort of thinking about what are things that can be triggering when somebody comes from behind to feel your thyroid. That, even in somebody without strangulation trauma, that might be something, but for some people it is. And so for we talk about sort of the little t and the big T traumas, and sometimes these are a lot of little t traumas. It was very uncomfortable when someone came from behind. It's very disconcerting when somebody like takes your gown down altogether and then says, it puts a stethoscope and then says, I'm going to listen to your heart. Like, you're now completely vulnerable, and only now are you realizing the context of that. So part of it is on us to sort of teach the clinicians to sort of say what you're going to do before you do it. And
about the piece of just like the emotional piece of medical trauma, like just being like not heard and not seen, which would you classify that as trauma, as medical trauma?
I think it's a very particular kind of trauma that is that has to do with a sort of sense of validation and a sense of sort of being supported at a time of vulnerability that is a little bit, it's a little bit different than the ways in which physical trauma can manifest, because we can sort of think about with the sort of physical trauma being really proactive, whether you feel comfortable doing it, but sometimes it's actually asking some other clinician that that you've trusted to sort of, listen, can you tell them I've got this trauma, please do it in this particular way. When it's about sort of being supported or not supported, it does become a little trickier, right? And so part of it becomes how much do I need that external validation, and are there ways that I can feel I can gain that sense of validation outside of that exam room. And then the other piece is really thinking about, is this particular encounter going to be one that's going to help that trauma or not? Because that sometimes walking in feeling as though this person in front of you isn't going to be helpful because no one else has been, kind of sets up a dynamic. You're sort of talking about this antagonistic dynamic, like everybody's kind of now on edge, and it becomes really difficult to have an integrated conversation. So I think having another place to process what that validation or invalidation was about and how it felt, and then to sort of think about, okay, so how can I ensure that that doesn't mean that I don't feel like I have any control when I go to this next appointment? Like, what is it I'm trying? They can believe me or not believe me. What are the very specific things that I'm trying to achieve with this or understand about this? And sometimes, being actually more specific and more concrete can be actually quite empowering, because if what you're trying to do in a 20-minute encounter is feel validated, some clinicians are really, really good at that, and that's really great and special. But as if you're sort of navigating a system in a way that you want to optimize your own care, I think thinking then about
what do I need and how
what do I need and how can I have them help me get a little bit closer to that is useful.
Yeah. That makes sense. That makes sense. I think it's also interesting, I mean, to think about, just to go back to that antagonism and the system that is splitting patients and providers apart, and that a lot of obviously patients are feeling traumatized and like they're not getting what they need. But I think to also remember that the providers are feeling so traumatized right now and under the gun. Maybe I shouldn't use the word traumatized, but burned out, for sure.
Mm-hmm.
And there's a humanness, I think, on both sides that gets lost. One program we have is, we call them patient provider healing story sessions. And we have the patient and the provider side by side, each having worked separately on a narrative guide, but they're engaged in a therapeutic relationship, share their stories. And it's kind of playing with those boundaries that medicine sets up, like that the provider is never supposed to talk about themselves, but in a safe way, where we can actually hear both sides, both stories, and it really humanizes and I think heals that relationship, because I think it can feel really tense. And I think providers often get really defensive. But I do think sometimes that comes out of them feeling like saddened by the fact that they are failing at taking care of patients the way they really want to. And the system is the problem.
Yes. I think when we talk about trauma-informed care, there's a parallel lecture of trauma-informed care for the clinicians as well as the patients. And I think, the idea of sort of feeling helpless, and I think this happens with some of the tick-borne illnesses as well. Sometimes you just feel kind of helpless. I totally believe what you're feeling. I'm not sure what to do about it. And sort of sometimes just feeling empowered to say, I'm not sure what to do, but maybe sometimes patients can handle that, right? Yes. I'm not sure, let's try this. That's better than saying something that feels really invalidating, like there's nothing I can do to help. This is it stops the story, and it's that can be.
But unfortunately, I think often providers are the ones that can't handle saying that, because I think that we're trained to believe that we have to have the answer. And so then too often providers will go to, it's nothing, because maybe medical science hasn't defined it yet. But, I don't think we're trained very well in medical education to say, I don't know.
Yeah. And I think the time factor is you raise that. I think it's a really important. I think I actually found it helpful for me going to doctor's appointments, understanding like what is the appointment duration, right? Like sometimes it's like 15 minutes and they've come in, and I just sort of think like, what can we do in 15 minutes? And so much about sort of building trust and understanding someone in an hour just takes longer. So I do think there's this challenge in the system right now that's just kind of compressing things that can't always be compressed. Sometimes you do need sort of time and space to create sort of shared understanding of values, goals, and so on. Yeah.
It can't be compressed, but then and certainly like I started by saying like, I thought I have to create something outside of the exam room because we can't do it in the exam room. But I have thought, since I've been on the patient side, like, how can we make those 15 minutes better? Like from the provider point of view, like what can we do? And I think talking less, listening more, but often we are tasked with sort of, I think we need to take the pressure off and say we might have to have multiple visits, but to listen more to I think since I've been a patient, I'm much more like, I am a guide and I will tell you what my knowledge is because that's my job to share it. But ultimately, it's going to be up to you what you want to do with that. Instead of, I think often providers have a lot of ego involved. Like, this is what I think you should do. And then people feel like if they don't do it, they're failing.
Mm-hmm. Yeah. Finding that kind of mutual understanding is definitely, I think, part of what makes the relationship work or not work.
Yeah.
Yeah.
What about oh, you go ahead.
I was going to ask in all the stories that you've now heard, I thought it was really interesting that agency changes before those kind of mental health symptoms do. Is that something that you've continued to see as you've expanded this enterprise?
I mean, certainly we are not measuring it, so I can't say like scientifically I have seen, but John Adler does a lot of science, and certainly that has continued to be shown that and I think that's what I loved about it. It's just that that we are in charge of how we finding those themes in our stories, and that we can then take charge of our own health in a way. That hasn't like been studied as well with some of the other themes, but I was struck in just sort of thinking about some of the resiliency factors that you talked about, sort of the protective factors. There's a lot of overlap, like communion, social connections, as you called it, or empowerment or being in control. That's agency. So there's a lot of overlap with these themes. So I think helping people to explore them. Yeah.
Yeah. I think the fact that it keeps coming back to these common themes is reassuring, isn't it?
Definitely.
Fantastic. Thank you both. And with your permission, I will also call you Annie and Nomi, but thank you very much.
Thank you.
Please.
Doctors Brewster and Levy-Carrick and Annie and Nomi. So thank you so much. I thought that was fantastic. It is remarkable how much integration and connection and in many ways synergy there is between these different approaches. I just want to transition now to some questions that have been brought in from people around the country, around the world, who are very interested in hearing your thoughts. Many of these questions, I'll tell you, are very personal and very much related to individuals' lives, individuals' experience, their own stories. And we are getting just a tiny snippet through their question. I like what you have described in terms of a number of themes that you've seen in your work. And we saw a number of themes in the questions themselves. I just want to remind people that you may hear a question and you may say, oh, that was my question. But I just want to let you know we've tried to anonymize some of the questions, and we've tried to combine some of those things. We won't get to every single question today. We just don't have time. And I really want to thank everyone for bringing the questions into the conversation. I will say that many of these questions are the kinds of questions that we wanted to address on our Lyme disease website. And so I would encourage you again to go to www.lyme.health.harvard.edu. That's a little bit of a mouthful, but lyme.health.harvard.edu, because I think you may find some helpful answers to questions there. So let's start. One of the themes that has already been brought up, and it's interesting that this idea of what do people who are patients with chronic illnesses, what do they feel? And one of the feelings that we heard over and over again in the questions was this sense of being dismissed or disbelieved, not believed by clinicians. So I'm going to just start and ask question. I find myself second guessing the history of my own illness because my recovery has not been linear, hasn't been straightforward. How can I, or is it normal to lose trust in oneself, in yourself, during the course of a long illness? And I'd ask you to answer this, both Annie and Nomi, in what do we know about this, and what could we say that would be helpful in terms of the techniques you've described, both in terms of the power of narrative and the power of thinking about things from a trauma-informed care. So second guessing the history of your own illness because recovery has been not straightforward. So Annie, maybe you want to start?
Sure. Well, I'd start by saying, sadly, I think that's a very common thing with chronic illness, and especially with illnesses that are poorly understood by the medical establishment. I've seen again and again, people start to doubt themselves, not just the nonlinear journey, but you're so negated by so many people who don't believe you, who say nothing's wrong, that you start to think, maybe I am crazy. Maybe this is all in my head, whatever that is. We should talk more about that, right? Because obviously there's no such thing. There's no such dichotomy, body, mind. But I think it's a very common thing, unfortunately. So I'd say to ameliorate that, one thing would be if it's a nonlinear and you go through phases where you feel better and you're like, wait, did I ever feel that way? Writing it down, writing can really help, keeping notes, even if you're not doing like a full cohesive narrative at that time, but just writing. There is extensive research on just writing about emotionally charged situations and material that is very good for us. And it will also be validating to read back and say, yeah, I really was in that place. Also, I think surrounding yourself by people that believe you, which is not always easy, but trying to find those people can really help you find your trust in yourself. But I think it's also a process. Like sometimes people over time finally have to sort of refine themselves, might go through a low point where they do start to doubt themselves, but then hopefully reconnect with that trust.
Great, thank you. Nomi?
I think, yes, so whatever normal is, that's a very familiar theme in chronic illness. And in some ways, when it's really chronic, you expect it to go up and down, right? It more often is nonlinear than if you're, in a particular phase of disease where it won't be. And I think, one thing I sometimes suggest is actually just making a list. For some people, actually trying to write anything narrative, a complete sentence is just too daunting. But kind of keeping track of when was a good day and what else was going on during that good day can be quite useful, or good week. Because the context matters. We sort of talk about this vulnerability to resilience spectrum, and where you land can, like, sometimes it's before and after a coffee, it feels different, but also at different phases of life, that there's just different things going on at the same time. And sometimes with chronic illness, you've also then got another illness superimposed. Like getting the flu on top of whatever chronic illness can just be, it can take months to recover instead of weeks, right? And then sometimes you look back and you can't remember why it was such a bad set of months. And then it's helpful to remember that this was sort of acute on chronic. And it can all just become this kind of blur in the absence of some points of delineation.
Great. One of the interesting questions relates to people who are looking at you as an individual. And so how do I make people understand how sick I really am, when some of my symptoms are invisible? You have thoughts on that? There are related questions about someone who says, I feel angry that it took me 2.5 years to get diagnosed, and for doctors to validate my symptoms as not being false or fake. They were real. How do I move forward with the medical system now? So how do you help people? How do we help people think about interacting with the medical system and friends or colleagues or others who might not see the way they really feel themselves?
Yeah, I'd say, I mean, I feel like tired just thinking about that question, because I feel tired by why should it be the burden be on the poor patient to have to convince people? That feels exhausting, right? To have to convince people that this is real when you feel crummy, that like the burden is on you. It's unfair. I guess I go back to trying to surround yourself with people who don't make you feel unvalidated, so you don't have to do that. Now, that's not always possible. Like, what if it's someone in your family who you can't, who you aren't going to be able to get away from in that moment? What if it's your child? You know, whatever it is, it's hard sometimes to separate yourself. But if it's friends or if it's physicians, like if there is a provider who really makes you feel like you have to keep trying to prove it to them, I would find a different provider. I might first try, if you think it's worth it, to have a conversation with that provider and say, you know, I feel that I have to keep trying to prove it to you. I feel negated. That may be met with positive response or not, but otherwise find a different provider. If you're around friends that are making you feel like you have to prove it to them, you know, try to surround yourself with people who believe you. But that's hard. I know in this world, it's hard. And when things aren't visible, the burden is on us sometimes to convince people. And
Do you think that by writing and sharing that narrative with either healthcare provider or friends, is there power to leverage that story?
Huge, huge, huge. Thank you for saying that, because yes, so much of the benefit is in the sharing. So often people invite their loved ones, their families. I've had people say to me, it opened up a whole new conversation in our family to hear this side, because you're able to reflect and say things that you might not have said or feel safe enough to say out loud. But when you really step back and write them and then share that, it can feel safer, and it really can open up a conversation. And just sharing a lot of the live storytelling we do, some are private, some are open to the public, but it is so much. There is a lot of research too on the benefits of sharing for the listeners. So it moves them to a different place, but it really can cement and open up new dialogues and relationships when there is this misunderstanding. So yes.
And Nomi, how do we help people who, let's say, you said that there are similar talks for physicians to understand the trauma-informed care approach. How would someone help a caregiver understand the trauma-informed care approach, which might be very helpful as a caregiver?
So, you know, I guess there are a couple of things. One is sort of figuring out what you need and what they need to kind of get through the day. Something that can happen with chronic illness is sometimes you want to be asked how you're feeling. And when somebody doesn't ask, it feels as though they're not seeing you, they're not seeing your illness. And other times it can be that you get really frustrated because they only see you as sick, and you've become nothing but that illness to them. And it becomes people sometimes, and we'll see this sort of caregiver individual kind of tension around, like, no matter what I say, they're going to get upset at me. So like, I don't even bother them. It becomes a sort of this tension in the house, actually, a real kind of antagonism. And so sometimes a really helpful thing to do is to sort of say, what's the question that I should ask? Like, how are you today? Might be a really good opening question. Because how are you today is really specific. It's not assuming anything, and it gives the individual or the patient an opportunity to sort of signal, today's a rough day, today's a better day, you know, and to sort of take it from there. Sometimes actually it sounds a little bit silly, but actually having a discussion about how to have a discussion, some sort of mutually agreed upon sets of discussions about that can really create a bit of space, because after a while, people will kind of get in their corner, and then you've lost the ability to engage, and then you're kind of talking in circles. I mean, the other thing I'll say, this is not to put everyone in a mental health basket, but I would say that one of the roles of having a therapist at some point around in this process is just because it's somebody who's in your corner, who's not family, who's not friends, who's not the clinician, that you can actually process this with. And I think it's incredible if you're able to do it in writing and through that narrative process. But sometimes you actually have to work through it to the point where you can gain that language. And I think it can sometimes be stigmatizing to sort of say, oh, you know, if you get a therapist, that you're invalidating. But actually, I think it can be an incredibly empowering thing to do, because it starts to give you a space to sort of find yourself. So I want to sort of
Thank you.
leave that there.
I agree. It can be very hard to find a therapist these days, though, because there seems to be a shortage, but it is super important. And another thing I'll just say about sort of like the dynamic in the exam room, like, and I'm thinking when I was a primary care doctor and like really was feeling that tension and that antagonism, sometimes I would try to sort of disarm it and just say, hey, like we're on the same team. Like, this is horrible for you and this is horrible for me. So I wonder, like, as a patient too, if you could say sometime, like, I understand this is super hard for you. And this is like, just to like level the playing field or disarm somehow that defensiveness that can come at you, to acknowledge like, this is hard for you. I see that. And this is hard for me. And we're on the same team. Doesn't always work, but just a thought.
That's a great segue into the next theme that we heard a lot of questions about, which was about coping, which is that the reality is that in chronic illnesses, it's chronic, which means long-term, and it's an illness, and it's not fun, it's not easy, it doesn't feel good. So one question that is written about how do you, but I think it means anyone, how does one find happiness and joy when symptoms are debilitating? It's a challenging question, but I'd love to hear your thoughts.
Oh, it's so hard. I mean, but I think it's about reframing. It's about redefining. What does joy look like? It can be a tiny thing. It's like, I try to have like a gratitude practice where I'll list like 3 things at the end of every day that I feel grateful for. And it can be like my cup of coffee. It can be tiny, like to find those little joy moments. So it can be hard when you're suffering, but to find those little moments, I guess.
Yeah, I think social connection and meaning making are like the 2 core pieces.
So talk a little bit more about those 2. Social connection. Could that be a community of people who are going through similar things, or is that what are other kinds of social communities?
Again, I think the interest, I know, like I had one patient who like also really loved knitting, and she was like a little tired of always being sick or talking about it, although she needed that too. But sort of, she had like a Monday group, a Tuesday group, a Wednesday group. Like Wednesday was her chronic illness group, but Thursday was her knitting group. And the thing she liked about that is that she was kind of in a group and doing something where she didn't necessarily need to talk about herself. She could, but she wouldn't necessarily need to do that. And that became very useful as a way to feel connected to people without necessarily having to do that. So I think finding those different spaces is really helpful, and kind of recognizing that for most of us, we need more than one.
I like that. More than one life, more than one attitude, more than one experience is super important. And that relates to the next theme that we heard a lot about, which was the new normal. So there were questions that range from, will I ever feel normal again? A difficult question for us to ask, not knowing, or not to answer, with not knowing where any one individual is. But here's a specific question. I understand that my life has been changed by Lyme disease, but I don't feel quite ready to create a new normal because I miss so much from my old life. I'm in a state of limbo between one and the other, grieving what I've lost. How do I move forward?
Grief is such an important part of chronic illness, I think, and navigating that it's something you can't ignore. I think, Annie, you've probably said it better earlier. If you don't talk about it, it just stays there as opposed to getting resolved.
Yeah, I mean, I think that exactly, that is some piece you have to move through. And for me, I think about movement, that there's always movement. And that's why I sort of ended with, we're not stuck. So we're not going to be in that grief forever. We need to feel it, but we also need to remember that there's a new day and a new there's movement, there will be movement, there will be another phase. And hopefully we move through that, and but it has to be felt.
Are there writing prompts if someone was listening to this and they said, well, is there a question or a series of prompts that I could ask myself or respond to each day where there might be evidence of that adaptation and movement? What are the ways that you might encourage people to ask themselves about these things each day?
Yeah, I'm less used to thinking it on a like day to day, because when we work with people, it's more sort of a longer arc, but I'm trying to think of sort of how you could apply sort of the same sort of turning point model. You could think about sort of what felt good to me in my before self, and where am I now, and where do I hope to go? I think to think about what is it I would like to reclaim, what is different, just articulating and pondering on those things can help with that sense of movement.
And related to that, I wondered if one question was, how do you share with people that an illness is chronic? How do you express the chronic? So there was a question that said, how do you convey to people that your illness isn't just a short-term inconvenience?
I mean, sometimes when we role play with patients, sometimes in the room, like, what am I going to say? I mean, sometimes it's literally saying it's a chronic illness. I have a chronic illness, and there are good months and bad months. You know, we have to kind of communicate together about which is a good month and which is a bad month, and what that means in terms of like what I can do this month and not, and so forth. But I think actually naming it for people is it's really interesting. People will sometimes really not want to, partly because like once you've said that out loud, you're worried that that's how people are going to see you.
Yeah. I mean, I can speak to this personally, just wanting my loved ones to remember always, but not wanting them to necessarily talk about it. I mean, this is just me. I recognize that sometimes I put them in a bad situation where I'm like, I don't want you to always be like, oh my gosh, how are you? Are you okay? But I don't want them to forget it. It doesn't seem that hard, but for some people it is in my family to even, I have been like, my husband has even said to me, I forget you have MS because you seem, and that bothers me so much. Right. So I try to define for myself, what is it I want? And people can do it. I want an acknowledgement that it is informing my every day, and it's always on my mind, even if I'm not in a symptomatic period, and it informs everything. But I don't want it to be dwelled on. I want people to just be attuned to that is what I want. And it's a tall ask, I guess, but I want people in my life that can do that. And I think it's important, but I think we have to be clear about what we need, and acknowledge that it waxes and wanes, and it's chronic, and it's always there for me, is what I would say.
I was thinking very much about something that Nomi said earlier about needs, and that I'm fond of saying that every interaction between two people, whether that's spouses, whether that's parent and child, whether that's student and teacher, there's always the doctor and patient. There is always this sense of negotiation of needs, right? When you go to see a doctor and the doctor is on this crazy time schedule, which I totally agree with you is a dysfunctional aspect of our system, that doctor has a set of needs. I've got to get through so that I won't be late for the next person, and I get, this sort of thing. And the patient has a set of needs that are often at direct conflict with their clinician. And Annie, that you described that beautifully as like, we need to come up with something that solves these, dysfunctional needs. And I think my hope that someone listening to this says, boy, I'm going to think about it from that perspective of what do I need? And I'm going to express that to either the person who's with me, the person who takes care of me, the person who is my medical provider. That I think is a key element of what do I need? What do I want? That sort of thing.
Yes. I want to sort of expand on what Nomi said about that, because I think it's so important. Sometimes, even if we say that, we might not get it. They might not be able to validate us and meet us in that moment. But there are times where we have to sort of selfishly say, from an empowered place, I'm going to get what I need from this doctor. That maybe I'll find this other doctor who will serve that part, but from this doctor, I need this referral or whatever it is. And we just got to get what we need, and we might not get everything. And that can be adaptive to think about it that way. Like, hopefully we can find a provider that validates us. But if we can't, or if we have lots of different providers, we have to think, what do I need and how can I get it?
Yeah. And I think sometimes that's the hardest question to answer.
Yes.
Sometimes you don't know what you need that day, and that's part of the challenge, right? And I think one of the vulnerabilities as a patient is like, sometimes when you're really sick, you don't know what the next step should be, and you're kind of relying on this person to tell you, and if you feel like you're not getting an answer, but to sort of Annie's point, if you can sort of say, what can our next step be? Sometimes that's like a very organizing question. You know?
Yeah.
I think that's great, and it connects to what I'd like to be our last theme for the day, which has to do with healing, and healing through storytelling and through the experiences. And I wondered, Annie, whether through your own personal experience, whether there's something that you could share that would provide hope to people who have say, well, Dr. Brewster was able to overcome a challenge and to see a positive change in her life, or whether you, Nomi, could share something that you've seen from either one of the patients who's worked through the trauma-informed care model and had some real benefit from that. But I think people are really looking for not only a sense of healing, but also inspiration.
Hope, possibility. Yeah. I mean, I will say, like, so many of the people that I've worked with have been so inspirational to me. And I've seen so many positive outcomes, but one, I mean, and this does not necessarily have to do with the work we do, but I'm thinking of like Elizabeth Jameson, who's a woman I've worked with, who is someone who has MS. And it's for me looking at her and how she's continually redefined herself because she's had to, but she's created these new versions of herself. So she was a public service lawyer who was like arguing in court. When she first got diagnosed, she lost her voice. She couldn't do that anymore. She went to an art class. She'd never done art before. She became this amazing artist, took her brain scans, look her up, Elizabeth Jameson, makes these most beautiful pieces from her scans, had this whole art career. Now she's quadriplegic from her MS and she can't use her hands anymore, but now she does, with the help of an assistant, a lot of writing, and she's been published in the New York Times. And to just her continually this hard road, but redefining herself again and again and again, and having the courage to do that and finding, what can I do in this with what I have right now? That inspires me.
That's an amazing story. I will definitely go and look those up.
She's amazing. Yeah.
I feel like we should end there. I mean, I can also say that, I have a lot of patients who have found their way through, but by really, part of it is the sort of the meaning making is sometimes like, what is actually valuable and important? Who are the people who are valuable? And the illness somehow makes that a really important thing to define. Sometimes we can get through life just kind of being reactive to the world we're in. This makes you kind of be really proactive to identify that. And so I think that lots of patients who've, in the process of identifying who those really important people are and what those really important issues are, actually feel like they're living a life with an enormous amount of meaning and connection. And that's really what we all seek, right?
Yeah, and just to add to that, like to remember, like your lived experience of navigating a challenging health condition, you've learned a lot. You have perspective that's so valuable. You have lessons to share with other people, and that's a skill, and that's so necessary, and that's healing to others, and that's agency. And you have that learned experience that's valuable. To remember that.
Thank you both so much. Those stories will stay with me, and I really want to thank you for your time, for sharing your experiences, for sharing your approaches and your strategies. I just really enjoyed the conversation and have learned quite a bit. I want to thank my colleagues at Harvard Health Publishing and across the Office for External Education here at Harvard Medical School. I very much want to thank our sponsors. The Fairbairns have been very generous, and the philanthropic fund that they set up has really had a significant impact and enabled us to reach so many people with wonderful and helpful information. I would encourage everyone, we will be sending out a link to the recording of this event, but I encourage you to share that with others. And I encourage you to go to www.lyme.health.harvard.edu, because there's a lot of great information there, and we encourage you to share that with others. I wish everyone healing, peace, and continued recovery. And as Annie said, you're not stuck. It's you're at a place that is changing. I really hope you continue to find goodness in each of those next phases of your life. So thank you for joining us today, and I'll look forward to our next event. Thank you.
Thank you, everyone.
Thank you so much. Thanks for including me.